Hey, good morning, and welcome to the UroPatient podcast. I'm your host, Vic Sinise. Welcome to the show. We meet here every Saturday at 10:30 a.m. And if you're watching us live on YouTube or Facebook, glad to have you on board. You can learn more about the show by visiting us at UroPatient.com, the best place to go to learn more about our show. Also, you can find all of our past episodes. Remember, this was created for you, the patient out there. I also created all these helpful handouts. Every time I have an episode, I've got a handout to go along with those episodes. You'll find them helpful. Check them out anytime. They're there for you guys. All right. Well, let's get into our talk here. We're going to talk about Botox for overactive bladder. I got some tips and tricks for you. So let's talk about, first of all, why we do this. What are the symptoms that we see with overactive bladder? Well, as you see this guy here, you run into the bathroom, urgency, frequency, getting up at night. Sometimes the urge is so strong you don't even make it without wetting yourself a little bit. So urge incontinence. Any of those would qualify as overactive bladder. So let's talk a little bit about Botox. Botox was first approved in the U.S. by the FDA in the late 80s, and it was approved initially for eye orders such as eye muscle problems like crossed eyes or uncontrollable blinking, or things like crazy things like that. It wasn't until 2002 that it got the approval for cosmetic use, specifically kind of getting rid of these frown lines between your eyebrows. And of course, now they inject any little wrinkle on your face to help relax that and improve your appearance. So I hear. Botox works by temporarily blocking the release of acetylcholine, a neurotransmitter that signals muscle contraction. By doing so, it causes a temporary muscle relaxation, which is what we want. So if you have an overactive bladder and you start injecting this Botox in there, you'll relax part of the bladder and kind of break up those signals and get a more normal bladder capacity and holding. Now, it's not considered first-line therapy, and in order to go on to have Botox, you typically have to fail first-line therapy. So what is our first-line therapy? Well, that's typically our oral medications. So oral medications are successful and can be used to reduce the symptoms of overactive bladder. It's our go-to drug. No pun intended, or maybe pun intended. There's two types of drugs that we typically give for the bladder. One are anticholinergic medications, such as oxybutynin, tolterodine. And the other is more new, called the beta-3 adrenergic agonist. So one is a blocker. The other one is a relaxer. Behavioral therapy is another option that we can go to, and that's the Kegel exercises. So we haven't talked about that, but that is considered first-line therapy. Teach somebody how to do Kegels. You can actually get good effect if you do them, but you got to keep doing them. That's the problem. So with the medication side effects, and people drop out and get tired of taking the drugs. With the behavioral stuff, people get tired of exercising and doing it because it may work, but once you stop, it may not keep working. So what do we do to select our patients? Well, medical history, physical exam, and, some shared decision-making makes a lot of sense. If the patient buys into the treatment, it's a lot better that they're involved in the decision of what they're going to try and how we're going to go about this. So some patient advocacy here. Most insurances only require failing one OAB drug. So that's enough to go on to second-line therapy and try something like Botox. And we do know that failure rates are pretty high with the drugs based on side effects, as we talked about. And, sometimes just people getting tired of taking medications and stop them. So all sorts of reasons that we fail them. Sometimes it can be cost. Some of these medicines are more costly, like the betas are less coverage on, for Medicare patients. We also worry about things like the anticholinergics can be increased risk of dementia in our elderly. So there are some good reasons that we might not want to put them on that. So let's talk about how we do this. The big thing is that you want to make sure that, number one, they're not taking any blood thinners. Really important, because you're going to be sticking needles all over the bladder. And if it starts to bleed, you're not going to be able to see from the first needle stick to the last needle stick. The second thing is urinary tract infection, because you're going to instill lidocaine in the bladder. That's really the only and the best anesthetic necessary for this. The lidocaine does a great job of numbing up the bladder. So, again, it should stay in the bladder for about 20 minutes to really get a good relaxation or numbing effect to the bladder. So now let's talk about the actual administration of the medication. Again, we're using their video, but I think they did a nice job. So why recreate the wheel?
Single Botox treatment can be delivered with rigid or flexible cystoscope and consists of 20 intradetrusor injections of 0.5 ml each. We will demonstrate the use of a flexible cystoscope. This is an example of the typical equipment setup required for the procedure. Under direct cystoscopic visualization, insert the needle approximately 2 mm into the detrusor after penetrating the submucosa. When injecting the needle, you should see a subtle rise in the bladder epithelium. If the injection is too shallow, a blistering effect of the urothelium may occur. Under direct visualization, distribute the injections evenly across the posterior and lateral bladder walls.
Really quick procedure. Not as quick as it is when you put it in high speed, but it's definitely a quick procedure. So safety, one of the common side effects of this, so safety and adverse events, the common side effects, of course, we're sticking Botox in the bladder. It's urinary retention. It could work too well. Fortunately, worst case scenarios, if they go into retention, is they just have to do self-catheterization. So all patients should be instructed that there's a risk of that, because sometimes it'll be temporarily, for the first few weeks, and then it goes away. Sometimes it can last till the medicine wears off. It's been pretty rare in our facility, but it can happen. Urinary tract infections, you're instrumenting a patient, that's always a risk. And then we're sticking them 20 times with a needle. So little blood in the urine, let them know that's common. If it was more severe, it could actually cause, clot retention, etc. The other thing is, although less common, they are more dangerous. There are some symptoms you want to make sure the patient's aware of. So because the Botox can sometimes travel and affect other areas, always give them this information. We have a sheet that we hand out like this one here. If they have right away, to let us know if they have problems with swallowing, speaking, breathing due to weakness of associated muscles, can be severe and result in loss of life. You're at the highest risk of these problems. You are at the highest risk if these problems are pre-existing before the injection. Swallowing problems can last for several hours. So that's one of the things, again, don't see it very often, but you want to warn them. Spread of the toxin effects. The effect of botulism toxin may affect areas away from the injection site and cause serious symptoms, including loss of strength and overall muscle weakness, double vision, blurred visions, drooping eyelids, hoarseness, or change or loss of voice, trouble saying words clearly, loss of bladder control, trouble breathing, trouble swallowing. If it happens, do not drive a car, do not operate machinery, or do not do any other dangerous activities. Probably just get yourself to the hospital. Due to the risk of urinary retention, only patients who are able and willing to catheterize themselves should be treated with this. So efficacy and outcomes, how well does Botox work? It's really pretty impressive. I mean, this is, patients who have failed other forms of treatment really can get a great result. Nice thing about it is sometimes this is really, really long lasting. Patients can get by with as few as 2 treatments a year. I've had a few patients that have gone even almost up to a year with 1 treatment. So it's pretty impressive. The minimum, just so you know, if a patient says that, hey, it didn't work, I want to come back in, or it stopped working sooner than 6 months, it can be done every 12 weeks. So that's the very minimum in between that you have to have. So in conclusion, Botox for overactive bladder is a great therapeutic option. It can significantly alleviate symptoms and enhance the quality of life. So I hope you enjoyed this episode. We'll see everybody next week on UroPatient.com.